Good morning and welcome to New Jersey Viewpoint. I'm Ken Rosato. Today we bring you the North Jersey Arts and Science Charter Schools who are using technology to deliver the curriculum to their students. We also have with us a young author who has advice for other teens in a new book. But first, we bring you some important information about ovarian cancer. According to the American Cancer Society, more than 22,000 women will receive a new diagnosis of ovarian cancer this year, and about 15,500 will die from that disease. Joining us in the studio from the Carol G. Simon Cancer Center at Overlook Medical Center are Dr. Daniel Tobias, the medical director at the Women's Cancer Center, Dr. Brian Slomovitz, the director of oncology research, and Jocelyn Alfandre, a patient with ovarian cancer. Welcome to the three of you. Thank you for being here today.
Thank you.
Well, first let me ask you what ovarian cancer is, Dr. Tobias, and why is it so difficult to diagnose?
Ovarian cancer is a malignancy or cancer that starts in the ovary and unfortunately has a predilection to spread very early on, and as a result we're not very successful at catching it early. So by the time most patients have symptoms, unfortunately many of them already have advanced disease.
So not unlike in a lot of other people say pancreatic cancer, it's that kind of a cancer, so that once you start feeling the symptom, by that point it's very difficult to treat.
In the majority of cases, correct.
Okay, so what are some of the symptoms that patients encounter?
Symptoms are sort of subtle, but can be things such as abdominal bloating, early satiety, feeling full easily when patients are eating, abdominal pain, urinary symptoms. So they're all symptoms which people have not infrequently, but occasionally can be symptoms of ovarian cancer.
All right, Dr. Slomovitz, what is the success rate now for treating ovarian cancer?
So right now we've been successful in making it more of a chronic disease, not necessarily something that people get and they suffer from over a short period of time, but we can have people living longer and having a productive life, but it still has very frustrating outcomes in the long run.
I mean, is surgery often one of the first treatments that comes to mind?
So right now in the treatment of the disease, it's a multimodality approach. It's surgery, where we actually do something very primitive in a way. We debulk the tumor. We get rid of as much of the tumor as we can. After following surgeries, we offer chemotherapy, and we're offering more novel therapeutics in addition to chemotherapy as a way to keep the disease away longer.
And Jocelyn, how long ago did you get your diagnosis?
I'm a two-time survivor of ovarian cancer, so the first diagnosis was in 2008.
Okay, describe what that's like to hear those words.
Indescribable, never ready for it, and I was uneducated, so I didn't really realize even at the time, even though everyone knows what cancer is, the difference between ovarian cancer and some of the challenges versus others.
Okay, and what is your treatment regime like right now?
Right now I am in remission, so I'm happy to say that I am on no treatment right now.
That's a good thing.
But the treatment regime the first time around was the surgery, so I had a hysterectomy followed by chemotherapy as well as participation on a clinical trial, which is one of the factors involved with picking a center like Carol G. Simon. And it went relatively well, and then I reoccurred 2 years after, and a similar course of action.
But at this point you were a little bit more aware of symptoms, etc., and so you jumped on it a little faster, I'm guessing?
Well, because of the care I get, I'm on a normal protocol to go back to the doctor, so I get tests all the time, and basically it was easy to diagnose when it came back.
Dr. Tobias, now we talk about clinical trials. When you have clinical trials, let's talk about this down to brass tacks, reality. Money. I mean, a lot of insurance companies won't cover clinical trials. So how's a person supposed to cover something like this?
Well, fortunately, most of the time our patients, when they're on a clinical trial, they're usually sponsored by the National Cancer Institute, so they tend to have coverage through their insurance. For costs oftentimes on a trial that aren't going to be covered by their insurance, the trial itself will pick up those costs. So for most of our patients, the cost usually isn't a factor for them deciding whether or not to go on a trial.
And there is always the worry that because it's a trial, I mean, it could be wildly successful, as was the case for you, or it could be something that does nothing for you. So this is always the risk you take.
Right.
When you opt for a clinical trial for a patient, how much background, how much study and research goes into that treatment regime before you offer that to the patient?
Right, so it really, that's a great question. It depends on the clinical trial we're offering. A lot of the trials we have are phase 3 trials, which are really confirmatory trials to see if it's going to be, it should be a standard of care. In order to get phase 3, there's years and years of research from the pre-science, from the preclinical work, into first-in-human studies, into phase 2 or activity trials, in order to get it to a type of phase 3 trial, which we'll see if it's should be available for all patients with a disease.
Now, one of the standard blood tests is called CA-125, and it's not that successful, correct?
Correct. Well, CA-125 is a good test to measure for recurrent disease.
Okay.
However, we've been using it, people are trying to use it as a way to early detect cancer, and off of a clinical trial, it hasn't really been shown to be a good way to see if a woman can get ovarian cancer. We are using it to better detect early stage disease, but it hasn't been proven yet.
Okay. What, I mean, is there a way of genetically, say, showing that maybe certain women might be predisposed to getting this? Do we have any genetic links for ovarian cancer that we know of at this point?
We do. So a certain percent of the population, maybe around 10% of women that have ovarian cancer, will have a genetic predisposition that can be measured in their blood through a simple blood test. It's called BRCA or BRCA. And those patients we know are much higher risk than the general population. And there are things we can do, both in terms of giving medication, which is called chemoprevention, or doing prophylactic surgery at the right time of their reproductive life to help prevent cancer in those patients. And that is very successful.
So now, is it better than, clearly, I'm assuming, I think I know the answer here, is it better than to go to a center like yours, where you have a lot of patients being treated for these types of cancers, specifically ovarian cancer, or do some of the larger hospitals, would they suffice, or if you live far away from a hospital such as yours, would they suffice in this kind of treatment?
You know, it's really not only an opinion. The studies have shown that in women who are suffering from this disease, if they are treated at centers or where they're considered high-volume centers, they could have a better outcome and live longer than if they're treated at centers that don't treat as many women with this disease.
Okay. How many women right now are at, say, your hospital being treated for ovarian cancer? Do you have a number?
We treat about 120 new cases each year, and the fact that women are living longer, so in our Women's Cancer Center, we're probably following between 800 and 1,000 women with ovarian cancer at any one time.
Jocelyn, what advice would you have for a woman who senses something's wrong? They go to their gynecologist, and gynecologist says, I don't find anything. Should they, I mean, would you recommend they just go for another opinion?
Absolutely. And we were talking about it on the way here this morning that ovarian cancer, for whatever reason, just doesn't seem to get as much attention as breast cancers and other cancers that have higher numbers of patients. So you have to be a little bit of your own self-advocate, and if you're really feeling funny, which was my case, I went to a doctor. I was told I was fine. I pushed it, and that's how I got diagnosed. So you have to be a little bit of your self-advocate and go with your gut, and if you're still feeling funny, go get a second opinion, go for additional tests.
And if a woman today hears the words from their doctor that you have ovarian cancer, what advice, what would you have to say to that woman today?
Definitely you want to seek out a treatment center that does have options, because there are great advancements being made in treatments or cures for ovarian cancer, plus the support you get not just medically, but the support you get emotionally, the facilities, everything you need to get through this emotionally is given at these high-volume centers that wrap the patient with better care.
Dr. Tobias, Dr. Slomovitz, and Jocelyn, thank you so much. All the best to you, good health.
Thank you.
And I appreciate all the efforts that you're doing right now in this research and this fight against ovarian cancer. Good to have you here today.
Thank you.
We're coming right back with the North Jersey Arts and Science Charter Schools. Please stay with us on this Sunday morning.